Just one more minute. Well, good morning, everyone, it's great to have you here. This is a CSJ event that will be looking at the future of prevention, treatment and recovery. Thank you all for taking the time to listen to this discussion. It's going to promise to be a very interesting one. We have some real experts that we're going to hear from. And I think it's important just to note that many of these discussions have happened in recent times. And really, the context of this is that it will serve as a reminder, a timely reminder to government that there's now a real expectation there's going to be delivery of meaningful and significant reform, that access to treatment and to recovery for addiction must be surely a reality, a fair and free and universally accessible reality for all in the UK. Many of you will feel that that's simply not the case today. And it's important that we continue to be vocal about what we rightly expect. We'll be engaging in a wide-ranging discussion, and we're very pleased to be joined by Professor Dame Carol Black, Professor Keith Humphreys, and Mr. John Royal. I just want to say something briefly about all three panelists by way of introduction, but they'll introduce themselves again briefly in a moment. Professor Dame Carol Black, a career in medicine and academia, and now I believe completed 4 independent reviews for the UK government, one on tackling addiction as early as 2016, and of course part 1 and 2 of the independent review of drugs. Part 2, of course, being a focal point of today's discussion. Professor Keith Humphreys joins us from the US, from Stanford University. Keith, researches on the focus of addiction and public policy, and served in the White House, both under the Bush and Obama administration. And of course, domestically in the UK, has assisted Dame Carol Black in the review of the UK drug policy. And we're pleased also to have Mr. John Royal with us today. John worked in both the residential and community treatment sector for almost 30 years as a volunteer, therapist and senior manager. Currently, he's the Chief Executive of the Bridge Project in West Yorkshire. And John is also living in a long-term personal recovery from addiction to drugs and is a former service user. He also sits as the chair of the board for the National Recovery Advocacy Charity Faces and Voices of Recovery. We welcome you all, and we're looking forward to your contributions. So we'll shortly be entering a panel discussion after some brief openings. Then we're going to move into some questions from the group. And we're going to ask that you, if you're watching this remotely, if there's something that you're interested in or something you think that hasn't been touched on the panel, and that's more than likely to happen in the half an hour that we'll go through the discussion, please post a question on the Q&A function, and we'll do our best to pull out that question and put it to the panel. And you won't hear much from me save this very brief opening. And again, I just want to expand a little bit on the context of today's discussion, because there's a lot in the air right now, a lot that needs to be decided by government. And these next few months and years are going to be critical to the future of many people's welfare in the UK. In recent times, we've heard various incumbents of Number 10 talk about social justice and equality and the need to really tackle deprivation in our community. We've heard phrases like tackling burning injustices, and we've heard phrases like levelling up. Indeed, when the Prime Minister, Mr. Johnson, stood at the doorstep of Number 10, he asked himself the question that perhaps many in the country were asking: what's he going to do with this extraordinary majority? And his response was clear and simple: unite and level up. Well, that's a reality that's yet to happen for many in this country. And when we look at addiction, it's stark. We should acknowledge some of the efforts the Conservative Party have made in recent times. In 2019, we saw their manifesto talk about taking and tackling addiction head on. We've also seen some injection of investment funding and perhaps even a new tone, determination, a new approach even of government. And with Dame Carol Black's report being warmly received by many in the sector, it was also heartening to see the immediate need for a cross-departmental approach to this, and a minister being appointed to oversee that unit. But we must acknowledge that drug deaths have risen starkly over the last decade, that people with significant needs are being turned away from treatment. If you have addiction in this country, you are not guaranteed a source of recovery. This is a scar on our social fabric, and it's also something that should weigh heavily on the minds of any government that claims to fight injustice and wants to raise up the welfare of people in our country. Today, we're going to explore in the best way we can the moral and even the practical case for doing better and for doing it quickly. And it's in that spirit that I want to turn first to the opening remarks of Professor Dame Carol Black. Carol.
Adrian, thank you very much. And I absolutely agree with what you've just said about the position we find ourselves in today. And just to say right now that in short, I said in the foreword to my part 2 of my review that government faces an unavoidable choice: invest in tackling the problem or keep paying for the consequences. The consequences are to the individual, their family, their whole lives, but also to society in terms of homicide, serious crime, and the overwhelming number of places in our prisons that are taken up by people with a drug dependency problem. I wanted just to start with where I started to get interested in drug dependency, because of course I'm not a professional trained in drug dependency, but I was fortunate enough in 2015 to be asked by Sir Ian Duncan Smith, then the Secretary of State in DWP, to do an independent review on how we could support people with alcohol and drug dependency back towards and hopefully into the world of work. And indeed to ask the question, would it be possible to move some of those people out of our benefit system and to give them a better life? As I did that research, I realized that work and training and something meaningful to do was so important if you were trying very hard to give up a certain drug. And it was something that stayed with me as taking a much more holistic approach to how do you help someone with a drug dependency problem, not just the clinical input. And I've kept close to the output of that review because what was started was a 3-year trial of individual placement support, a trial in 7 centres, 2017, now completed. And what that trial showed, that with really good case management and following the principles of individual placement support, you could enable many people who had previously been written off, quite frankly, to really bring about a positive change in their lives and move into the world of work. And this really became important to me as I started part 2 of my review, because I knew that to try and offer a solution to the problem, you couldn't just rely on improving what I might call clinical treatment and clinical input. So my beginnings in drug dependency really have influenced the way I have approached part 2. And I want to acknowledge the great contribution that Keith has made to that review. It's been wonderful having his support throughout it. As you know, part 2 was published in June, in July of this year, and I would say it simply laid bare a broken treatment and recovery system, a diminished and demoralized workforce, and wherever you look, worsening statistics. And of course, if you look at the more recent statistics which have come out following the pandemic, the situation is even worse since lockdown, and drug deaths are at the highest that we've ever seen them. In seeking to offer a way forward, we tried to have some coherent and well thought through recommendations. And we really did try to put the drug dependent person at the center, and then really to ask the question, what system needs to be put in place so that any individual would have a reasonable chance of a successful journey of recovery? And Adrian, as you said, that just simply isn't there at the moment. And we have concluded, and I hope we'll debate it today, that we needed a whole system approach, which demands, in where demand reduction was a key component to drive down that profitability of marketing drugs. We needed coordinated action by at least 6 departments of state working together in a central drug unit with a responsible minister on drug policy, holding all of government to account. We have been certainly missing that. And then it needed to be supported by a strong team to monitor the statistics and report annually to Parliament on the relevant social and indeed criminal justice outcomes. We needed coordination and accountability to flow through from the central to the local level. And that has been sorely missing, with local authorities required to work together with the wider health and employment support, housing support, and criminal justice partners to develop joint plans to commission services. It was quite a big debate whether we should leave the local authorities in charge of that delivery. Should it be returned to the NHS was certainly a debate that we had. We ended up by leaving it with the local authority, but that they should be held to account for the plans and the outcomes. Increased funding is, of course, necessary, and we are in, of course, a spending review at the moment. I hope we've made a good case to the Treasury that we really do need the support that would increase over the next 3 years of the spending that will be announced, I think, by the end of October. And we need it to be ring-fenced. If it's not ring-fenced, it will be spent on other things. And it's needed to provide high-quality clinical care, mental health and trauma-informed services, a peer-led recovery service, housing, and employment opportunities. This is a complex matter, and you can't do it by just doing 1 or 2 of those things. You need to do them all. I want to say right up front, and I've said this throughout the review, that I believe addiction to be a chronic health condition. Unlike other such conditions, it will probably have remissions and relapses and requires long-term follow-up. The recovery system needs to be strong and to have the capacity to be a recovery system that lasts for the long term. The review also seeks to break the cycle of going in and out of prison rather on a hamster wheel is experienced by far too many drug users. And we really, in the review, tried to make the case for diversion from prison and meaningful care after release. That's been so severely diminished recently, and this trend must be reversed to break the costly cycle of addiction and offending. My single aim in producing the review is to bring hope and real change to the many individuals and their families and communities whose lives are blighted and indeed shortened by addiction to drugs and by the criminals who exploit that addiction. So I hope that just gives you a very quick overview of where I'm coming from, what I was trying to, with all the people who helped me to achieve in the review. And I should acknowledge the great help that I received, not only from Keith, but from Ed Day, our recovery champion, and also from 6 departments of state who worked with me throughout the last 12 months. Thank you, Adrian.
Thank you, Carol. That's enormously helpful. And you certainly brought hope to a sector that's now determined to see change. And so can I just turn to Keith now? Keith, would you briefly give an opening?
Yes, thank you. And thank you, Adrian, and your team and CSJ for bringing us together for this very important discussion. I'm just going to say three things, which are, why is drug policy hard? Why do we have to do it anyway? And why is it rational to have some hope about what we can achieve? So think of the first thing, why is drug policy hard? There are social problems that fit very neatly within the remit of a single government department. And when that is the case, it's not easy, but it's not impossible to have a coherent, a cohesive policy approach to that problem. Addiction and drugs are just not like that. And you can see that, you sort of walk through all the domains where they have an effect. So you say, well, it's a health problem. So can medicine handle it? Well, yeah, yes, it can certainly do something, but it's not the same as hypertension, because you start getting into issues of how does the person get their job back, or how do they get housing back, which you don't have with other medical problems. And that brings in other departments. Then there's a law enforcement question. And you see this most prominently in this country with alcohol. If you look at the British crime survey each year, hundreds of thousands of people say, you know, I've been assaulted by someone who has been drinking. Those people will want justice and protection. So now the police are involved. So now you have the Home Office involved and the Ministry of Justice. And then there's a foreign policy component. In both licit and illicit markets, you have to negotiate things with other countries, whether it's to get them to stop underselling your tobacco tax or stop, you know, having illicit fentanyl shipped to your country, which is something, you know, we're working on in the States. So that's the coordination challenge. And it's tough because the one place where every government on earth always seems to achieve a fiercely competitive free market is among government agencies that are ostensibly supposed to work together. Government agencies like to do what they want to do, and everyone has their own agenda and their own interests. And I'm not saying there's anything evil about it, it's just the reality of how bureaucracies are. And you'll see in Dame Carroll's report the concern about how do we herd all these cats. And that is the logic behind the proposal, which is now being implemented, to have a designated unit with designated capacities and a designated minister to oversee all this. That's a great start. It doesn't, I can tell you, end the problem of policy coordination. In the United States, we have an office in the White House, which as Adrian mentioned, I worked in, which coordinates drug policy and has formal budgetary and statutory powers to do so. And yet, even then, there were times that we could not get agencies to work together. And there would be butting of heads between cabinet secretaries. And what it came down to, in every case I was involved in those arguments, was what does the leader ultimately want? In our case, the president, in your case, the prime minister. And when those choices have to be made, and they're very hard choices, will they decide, no, drug policy is the priority, there's many other important things, and it's so important that a lot of departments are going to have to set aside other agendas in that service. And so that challenge remains for this country. We've got a good start, but then when these things come up, what ultimately does number 10, what does the prime minister care about the most? So all that sounds hard. It sounds so hard that you can understand why many governments don't want to have drug policy or don't want to focus on drug policy. So why do you have to? Well, you come precisely back to the same thing. Because it hits so many different domains, there's really no way to avoid the impact of drugs and addiction on society. So if you want to put it to the side, pretend it's not there, you then start trying in your education policy, and you find some kids aren't learning, and they're growing up in homes with addiction, and their lives are disorganized, and that's impairing your educational goals, and your healthcare costs are going up, and infectious disease is spreading, and your prisons are full. And so you end up grappling with addiction, whether you want to or not. So we really don't have any choice but to build policy in this area, because it just touches so many other things. Now, last, just to close, are there reasons for hope? In the case when you work with individual addicted patients, despair is the enemy. When someone feels, I can't beat this thing, it's beating me, my life will never change. That's the recipe for doom. And a big part of what you try to do is instill hope. And this also is true of drug policy. Many people, the average voter, often feels like, yeah, this is sad, but there's nothing anyone can do about it. And so it's very important to remember that's not true. We actually have lots of things we can do about it. I'll just focus on, one thing: people who are already addicted. People come in and ask for care. We actually have treatments that work. Very hard work by clinicians and scientists over decades. We can help an awful lot of people get their lives back together if we have the willingness to provide those services. And for people who didn't want to come in, but are now under, say, the supervision of the criminal justice system because they got drunk and wrecked their car or got into a punch-up or whatever, we have things that work with that population. The monitoring program, which is being rolled out in this country, called mandatory sobriety, where you test people regularly and give them positive or negative consequences based on their use or their non-use. They really work. They reduce crime. They reduce substance use. And that's something else we have in the toolkit. We have also a new constituency that I'm very excited about, which is the recovery community is getting more organized and more active. And they, I think, have a commitment to this issue that is really without parallel. And the impact they can have and the stories they can tell and the optimism they can inspire is really great. And there's many things I could compliment Dame Carol for and how she pulled this report together, but one of them would be opening the process to people in recovery to participate really actively and get their ideas in it, because they are part of the key, part of the rational reason to have hope as we go forward in drug policy. So I'll stop there. Thank you.
Thank you, Keith. And it's always refreshing to get an international perspective, but it's clear that there's a lot of these issues to do with deprivation and the way that people approach addiction and enter into recovery that are a commonality across borders. I wonder if I could then turn to John. John, if you wouldn't mind giving a brief opening.
Yeah, thank you very much, Adrian, and thank you to the CSJ for the opportunity to join this panel. I think I was asked to stand in because perhaps a government minister or someone couldn't make it today. So, does that give me the legitimacy to perhaps make some spending announcements and commitments on his behalf? Well, I'd love to do that, but I'm sure that would be against the rules for me. So I think I better talk about something else. I really thought that I was going to start by talking about things like the consequences of the Health and Social Care Act and disinvestment in the state of the sector. And I did spend about half an hour planning to do that. And then, I just thought, all that, and you've lived through it. And, Dame Carol Black's report just was such an honest perspective of what the things are. So I thought, I'm not going to go there. I just threw that out. And instead, I think I just want to talk to you about some of my hopes and my aspirations for the sector and what I believe is an opportunity where we can learn from the past and we can make things right. And, we can be really proud about what this country is doing to tackle addiction. So I think at the moment, it does seem to be mainly reports and talks, and we're lacking that long-term commitment. But I do believe that at last we are being listened to, that the government's eyes have been opened by Dame Carol's review, and there's a genuine desire to do the right thing and give us back a world-class treatment system. I think that the Project Adder and the £80 million investment in the sector was a great start and a sign of intent, but other than a temporary boost, we're still largely in the same place, not being able to plan long-term to turn this thing around. So my hopes, my aspirations, I've got many of them, but I'm just going to share with you the big ones and what I believe are the priorities, and they're quite simple. Firstly, a national drug and alcohol strategy that we can get behind and I'll align our local systems to. And that's got to be ambitious, of course. And I wish it would include other forms of addiction, such as gambling, but I won't go there. I think that's too much to ask for. But at the very least, take alcohol as seriously as we take drugs. It makes no sense to us at the sharp end, where we see the harm that alcohol causes, that it always seems to play second fiddle and is constantly eclipsed by the drugs and crime agenda. For me, first and foremost, this is a public health issue, and we all know that alcohol kills more people and it's an even bigger health menace than drugs. Secondly, a real commitment to investing in the sector over the long term. We're asking for what Carol put in a report, what prorated would be similar to the commitment the Scottish government have already made over 5 years. And this is something we need urgently because there's just so much uncertainty. The wonderful charity I volunteer for, Faces and Voices of Recovery UK, we spearheaded a campaign in Scotland under the banner, "You keep talking, we keep dying." And that says it all about the strength of feeling in the recovery movement and its supporters. And unfortunately, we don't have the resources to mobilise a similar campaign in this country, but I do believe that the feelings are every bit as strong. So make that commitment so we can have the same equality of service provision across the whole of the United Kingdom. Next, we need to ensure that the structures in place to ensure that those national ambitions are delivered at local level. And you know, I think we can learn from the past here, in particular, the way the national treatment engaged at one end with the ministers and the government departments, but at the other end, they reach right down to local level and they talk to providers and user groups, as well as giving support to commissioners and ensuring accountability. And we really feel a disconnect now at local level, and I think we really miss that strong sense of being accountable. And finally, there needs to be an overhaul of the way services are commissioned. And I'm not saying that the big third sector primes that dominate the market today are not doing a great job, but we can't just see more of the same big one-size-fits-all contracts going out to tender. Commissioning needs to be much more sophisticated, and services need to be designed and planned at a local level by the partners who really know the communities and, of course, the people who will use the services. So that's it for me. I hope that's pretty clear and simple. And the sector is really full of committed people. Just give us those tools and enablers and we'll give you back a treatment and recovery system that the country deserves. Thank you.
Thank you so much, John. I'm sure that there are loads of nodding heads right across the country to all three speakers. Now, I want to just move into the panel discussion, and I should say this from the outset. I don't think we're going to hear from every single panel member on every single issue. And I should also say that, rightly, this is a policy area that involves a full spectrum of concern, from prevention and the role of family, commissioning, accountability, the role of residential rehab. We're not going to be able to cover everything in this discussion, but we hope that as we go through, we can then get into the Q&A and pick out some common themes that are coming through. And so I really want to start with prevention as an issue to discuss. And we do this in the context of knowing that Dame Carol's report, part 2, has explored many of these issues, but there's a debate here that I think Westminster and government still need to hear. And so my question for the panel is really this: how might we better prevent young people falling into addiction? What role does wider mental health service provision play in this? And I'll ask you to take this view. Are we being too narrow in looking at the addictions that we take on? Should we be broader in terms of our prevention strategy to look at things like gambling addiction and gaming addiction? And I'd like to open with Dame Carol. If she could start to answer that question, that'd be great.
Thank you very much. Adrian, well, I think as far as prevention is concerned, and of course it's not just drugs, you really, if you look around the country, then the worst places are those places where we have deprivation, where we have poverty, where we have young people who've fallen out of education, who are living perhaps in domestic violence. So I felt I didn't do a full enough job. There wasn't time to look at the sort of preventative things that should be happening in those communities, both through schools, but also there've been so much austerity. The things even like youth clubs, the sort of things that happened after school, the support, if you like, the preventative things that try to support children from falling into gangs. they were disappearing. So I would certainly make a big plea for all those things. I think also social media. Lots of young people told me that it was so easy on social, through what they could get to on social media. It was so glamorous to get pulled into drugs. It was presented as something really trendy to do. So I think there's the whole stuff around social media. So I mean, I think you should hear from the other members of the panel, but I think there was so much that I wasn't able to explore in detail, but so much of it does relate, I fear, to poverty, deprivation, and I suppose it brings us back to the levelling up agenda.
Thank you. Yeah, if I'd like to pull in Keith at this stage, if I could. And Keith, I'm asking you about strategies that you know that you see potentially abroad that work. Any ideas about what the future should look like in the UK when we take on prevention in a meaningful way?
Yes, so thank you. Let's start with the observation about how addiction is different than other health problems. If you're a cardiologist or an oncologist, it's an uncommon experience where you treat people whose problems started when they were young. They're usually diseases of aging, and addiction is really backwards that way. It's extremely unusual for an addiction clinician to meet somebody whose addiction started in their 40s and 50s and 60s. It's almost always in adolescence, in the extended sense of adolescence, meaning as the brain is developing up to about age 25. So that's where the name of the game is. And if we can push people, even if they're going to initiate use, if we can push it later, there are benefits for decades in terms of prevention. I would be broader even than you were, Adrian, about what we should be going for. Yes, gambling and all that sort of thing, but I would look at the fact that the research literature shows that the risk factors for a young person of getting into trouble with alcohol, tobacco, drugs are overlap very heavily with those from dropping out of school, having an eating disorder, being depressed, engaging in self-harm. I mean, pretty much everything parents worry about, there's common factors. And so getting out of the mentality that we need to have a finely tailored approach to stop young people from using drugs. Instead, say we want to strengthen those core capacities. And there are things like having safe and stable environments in which they can engage with responsible adults, learning how to recognize and manage their emotions, having support among peers, having connection to meaningful community, cultural, or religious, athletic activities that make life worth living. Those kinds of things, which we have some power to do in policy. It's not just policy, obviously families, communities matter, but maximizing those will help in the long term with our drug problem and also many, many other problems that afflict young people.
Very helpful, thank you. I'm going to move this on to a separate issue now. I want to look a little bit about how the country gathered data on the state of the nation, on how serious addiction is in this country and what works when we treat it. So looking at that, what gaps in the data do we see? What do we capture that perhaps we give too much weight to? And what sort of research would we like to see to develop our approach? And can I ask the panel, if they're answering those questions, to think about how the four nations of the UK might lean into helping each other more in a sort of union response to this national crisis? Perhaps if I can start with John.
Yeah, thanks, Adrian. Do you know, I'm to some extent, I'm thinking of this from my experience in watching the interventions and the services that we deliver, because they're all very much informed or should be informed by evidence and knowledge and research. And unfortunately, when I look back over my career, I can't honestly see much that we're doing things a great deal different than what we were doing 20 years ago. We're perhaps doing more of it. There's been some developments with new pharmacological interventions. But other than that, it's just the kind of same model of delivery. I think, you know, perhaps when we do see some good research come through and we do see some good evidence, there's one or two good examples of how it's changed things for the better. And, you know, the best one I can think of is the evidence around the effectiveness of 12-step groups and programs such as Alcoholics Anonymous. Because when I came into this sector in this country, it was largely just scorned and ignored by the mainstream treatment sector. But I think the work that Public Health England did on that and bringing together the evidence and the expert group and then promoting that in the sector, it's really won over the sector. And now you see practitioners who, you know, were completely hated that type of approach, now completely believe in it and are actually actively facilitating their service users to get into 12-step treatment programs. So I would love to see much more of that research coming out and informing our practice. But unfortunately, though, when you look at where the research is taking place, particularly in recovery, I only really know in this country of Ed Day and David Best, and I think that's quite terrifying, the lack of research that's going on there into recovery. And, you know, at first when we talked about recovery, I remember commissioners saying 15 years ago, how do we commission recovery? They're still asking the same question. So I would particularly like to see some research being focused on these emerging community recovery organisations. We know that what goes on in there is really magic. We see recovery happening there, but we just don't understand how it's happening. And I'd love to see more research focused there. And then we can start to invest in and develop and build up those models much more widely.
Thank you, John. That's very helpful. This is one of these questions where I think actually I will bother all three of the panel. So if we can go to Carol.
Thank you very much, Adrian. Just one comment about data. It has been and is still difficult when you're trying to get data from different departments. And I think that is one area that we do need to work on, the sharing of data. So let's say you want to share data between the Department of Health and Social Care and DWP. I found as an independent person, when I was trying to get that sort of data, you do go through quite a lot of hoops, and yet the matching of sets of data that relates health data to all kinds of other data you would like to be available. I may be corrected on this, but I tried to sort of understand if we had data, if you like, on long cohort, longitudinal data, as we keep with so many other conditions, because it would really be important to me to know, not just have we made an immediate success with someone in treatment, but really what is their longitudinal process. And again, I'm not sure that we're set up at all to get longitudinal data and to learn from it, because I think we could learn a lot more about what you do quickly about a remission, rather than let people really be terribly miserable before you intervene. I mean, research, you see it highlighted in my review. Really, once you're outside of the opioid drugs, then we are lacking research. I mean, John's just really highlighted something I felt quite strongly about, research in the recovery section of the process, recreational drugs and on opioid drugs. We have not had an interest or emphasis on research, and I think there is a great need to do something about that. And even at the more scientific level, you know, how much we just don't have a strong research community, but we have some very good people. So it's not a lack of people who are interested to do this work. It's really been a lack of support to encourage this as a field of investigation. And again, I would really love to see that change.
Thank you. Keith, I'm hopeful that you'll have something you want to ask.
Yeah, I would ask people to think about COVID-19 for a moment. 2 years ago, it did not exist. Yet at this moment, any of us could get out our phones and find out how many people in this country were infected with COVID in the last 24 hours and how many people died of it. Addiction and overdose have been around forever, and you still can't find that on your phone. And that to me is a statement, first of all, what we can achieve when we want to, and what we don't achieve when we don't make it a priority. And we need to have a COVID-like urgency about addiction and overdose to say this is just important. We need to resource it like we did COVID. We want everyone, every local counselor, I want them to know how many people that you're responsible for in your community have this problem, how many are dying, what resources are available for them. That's about a commitment. I want to also point people to something that Dame Carol and I wrote with Sir John Strang in the BMJ when the report came out, is that we're kind of worried about just the status of addiction science in this country. In the US, we're lucky we have 2 institutes at National Institutes of Health that are specifically focused on alcohol and drugs. There isn't anything like that in the UK. And I just don't see a lot of young people going into addiction research. And addiction psychiatry is kind of in decline. And that you can ride on the fact that you have this magnificent generation of people like John Strang there, but no one is around forever. You have to keep bringing in new people, and that's going to take organizations like MRC, for example, the Medical Research Council, to make an investment in the future and say, we need to set aside some funds for bright, young, passionate people to devote time to addiction as much as we would people who need to devote time to cancer and heart disease and all the other serious public health problems that we face.
Yes, thank you. Okay, I want to move on to discuss alcohol specifically. It has been raised in some opening comments, and I think it's worthy of a discussion. There have been concerns expressed by many in the sector that despite clear efforts that have obviously been made in part 2 of the review to pull within as far as is fitting alcohol into something that was commissioned to look at drugs in the UK. And notably, the budgeting is factored into a lot of what's been committed to in the Joint Combating Drugs Unit. But that being said, it is the Combating Drugs Unit. It sits within the Home Office, and there are some concerns, and I would say legitimate concerns amongst many, that this is perhaps indicative of alcohol taking a back seat and in government psychology, and also perhaps worrying about the future. As we plan the future and we plan it within a unit sitting in the Home Office, if it's not taking a backseat, could it later, as we start to lose focus on what is a very serious problem in our country? So really my question is, what should we be doing to make sure government recognises this need to keep alcohol front and centre, and how can we influence that response? I think maybe if I start with Keith on this one.
So, alcohol, ethanol is a drug. I'm not saying that to be provocative. I'm just stating a biochemical, psychopharmacological reality. And we all need to think about alcohol as a drug. And when we talk about drugs, it sometimes seems that, alcohol is the Atlantic Ocean and we have our entire Navy in the Mediterranean. And so much focus on the illicit drugs, which of course are important, but then overlooking the fact that most of the deaths and also most of the crime, most of the arrests, most of the prisons are driven by alcohol. I share the concern about it being split off. I have to say we had the same problem in the States. The White House Drug Policy Office has no authority about the adult use of alcohol, and that was a reflection, I think, of the influence of the alcohol industry, the political influence in the States, and I think that's here as well. But once you internalize that insight, alcohol is a drug, a lot of things can change. One, you can be a lot more compassionate, or I think a lot of people can. If you sort of accept they're not the same, you can sit at the pub and talk about drug users who are ruining this country. But when you say, wait a minute, I'm a drug user, lots of us are drug users, I think it opens up a little more sense of common humanity that most people use drugs. Yes, some are legal, some are illegal, but it's not as if it's some bizarre and deviant, immoral behavior to use drugs. Most people, use. I drink alcohol, therefore I am a drug user. Second thing is that the services themselves really have to be fused because it's fused in the lives of the people who seek those services. It's in fact pretty rare, in my country, and I assume here as well, that someone comes in and they only use one drug. Most people use lots of things. They mix the alcohol, heroin, alcohol and cocaine, and so on. So given that's who we're taking care of, the design of the system should reflect that, including in the financing. So personally, if I were king, I would want to have the same services with the same people trained, and that anyone could walk in and expect to get high quality care, whether they happen to be using a drug that is legal, or they happen to be meaning alcohol, or happen to be using a drug that is illegal. End of sermon.
It's very helpful. Thank you. Of course, Dame Carol, I think.
Well, just very, very quickly, because I really agree with what Keith has just said, but I do think you should take hope from the fact that in the money that we are trying to get for treatment is not delivered to just drugs or alcohol. So any of the money that goes to improving the workforce, I see it as being for both. I mean, I know I wasn't commissioned to look specifically at alcohol, but I very much hope that the benefits, if there be any from the review and rolling it out, would benefit those with alcohol. I think the positioning, Adrian, and I think it is worth a word of the central unit at the moment is in the Home Office. It was considered centrally that was, for the moment, the best place to be, but it does have contributions from 6 departments. I mean, physical people from 6 departments, including health. I have been really as insistent as I can be with the Department of Health that they must play a really strong part in the central unit, because it is crucial that is so. And also in discussion with the CMO, I'm really looking to him once they get going with the new, I hope I get its wording correct, the new Department of Health Improvement and Disparity. I think that's the name for that part of Public Health England. That there, I would hope that some of these issues will be taken up, and I am sure that alcohol is a concern there. So I can see various ways of really trying to ensure it's not left behind.
Thank you. And I should just say, there's a little note here, and I won't speak very often, but I'm watching the questions fly in, and what was coming a common consensus really is a lot of support for the report that you've written. But one question did catch my eye, really addressing the point of as to whether or not now we have a single unit taking on this thing with some really meaningful reforms. Where's gambling in that? Is it possible to bring it in? And I know that we've talked about not trying to make this too broad of a conversation, but it's worth noting that there are people that still feel a lot of this reform around recovery should be applicable to these sort of addictions.
And do you think that might come in? Isn't the Department of Health and Social Care writing an addiction, a strategy that is much more than just drugs?
So the addiction strategy up in the, I don't know what it says. I'm ambitious. I hope that it's not going to be exclusionary. It's going to include as much as possible underneath addiction. I think many of us, perhaps not all, but many of us will regard that there are core drivers behind that have real commonality, and it's not behaviour or the substance. It's really about addressing those. And a lot of the reforms you propose can go to the heart of those. So let me move on.
I just want to add one thing, if I could, Adrian, also just in the epidemiology. People who have gambling problems have extremely high rates of alcohol problems and tobacco and drugs. So again, when you go back to who is going to use services, they're not going to come in hermetically sealed containers. It's going to be a mix of things. So one should be prepared for the work one has in front of us.
That's helpful. Thank you. We've talked a little bit about government structures and budgeting, and quite rightly, and this is not exactly a departure from that completely, but I want to talk about, in a broad category, excluded people. So people who often find it very difficult to find access to treatment and recovery. And we know, we've all heard stories about people being turned away, dual diagnosis, all sorts of reasons why people get turned away. But for some communities in the UK, treatment and recovery is obstructed by additionally issues of cultural stigma or a lack of cultural appropriate provision, and it leaves real and concerning gaps. For others, they're obstructed by disadvantage and personal circumstances. It can even be domestic abuse, it can be sex work. There are lots of reasons why people find it very difficult to access treatment. If we can leave aside for a moment questions over budget and money for a moment, what more can this country do and what the government do to support outreach, to engage people who are perhaps left behind and excluded from treatment, and pull them into, or rather encourage people into a meaningful and lasting recovery? And John, can I start with you?
Yeah, I think the way I'd like to come at this is I think that one of the reasons that many people are excluded from getting the services that they need is about the way these services are planned and designed and commissioned at local level. It very much comes down to that. And the model that we see at the moment, it's very hard to tell the difference between one service system, one tender that comes out and another, where, whether it's in somewhere like a very diverse area like Bradford or somewhere perhaps less diverse in the south of England maybe. This kind of bland one-size-fits-all tender specification contract encourages an organisation to come in, probably a big third sector organisation that previously has had no connectivity or knowledge with those local communities, to come in and take over and deliver a whole system. And the small organisations that are out there, the grassroots organisations, often the voluntary sector, who really know and live with people and understand these communities, they're generally just left completely out of the system, or if they are in it at all, they're a very reluctant supply chain partner. So I think the key to this is really that, a totally different paradigm to the commissioning. These services need to be planned and designed by the people, the partners that really know local communities. It needs to be a much more sophisticated approach. And the people that are going to use these services need to be involved in that planning and design and commissioning program. I just want to add as well, obviously stigma in all its forms is the biggest barrier for people accessing services. And I have to make a plea here for the UK Recovery Walk movement. I got involved with Faces and Voices of Recovery because in 2013, I went to Manchester and I saw 5,000 people in the recovery movement walking through the city of Manchester, celebrating recovery, making it visible, people from all walks of life. And that movement just needs to be nurtured and grown and developed. We need to be open about recovery. It needs to be visible. That's what breaks down the stigma and those barriers and makes it accessible.
John, that's really helpful. Actually, Keith, would you mind commenting on that?
Yeah, I would. I'm so glad John took that question because I think he is the most important person on this question. When I worked for President Obama, one of the things I concluded was we have to change the face of this problem. We have to change the images that come to people's mind. And if it is someone, lying on a street corner with a broken needle in their arm, everyone's going to tune out, turn away, and be despairing. And so we had, the director of drug policy, instead, we had him out on recovery marches. We wanted, people to see the healing, the fact that there are 25 million Americans in recovery that contribute to their communities. They are wildly diverse. In every dimension, people can be diverse. And that builds hope. And also it helps deal with this exclusion issue that you mentioned, Adrian, about people of different cultural backgrounds or different, gender, age, or whatever, who kind of write themselves out of the story until they see someone like themselves. And they're like, oh, wait a minute, there's another doctor. I could do this. Or there's an African-American teacher. I could be that person. Or there's an adolescent. Or there's someone who's lesbian and gay. Or there's someone who uses a wheelchair. And so to consciously promote platform people in recovery, let them get their story out there. That's something all governments could do. And I hope that, I'd love to see the Prime Minister of this country out on a recovery walk someday soon.
Thank you. I'm actually going to do just one more question for the panel, because there's so many questions coming in from people watching, and they are really important questions, which I think go to the core of some of the considerations I have around justice and family and community, and certainly the role of lived experience. And I think we should invite the panel to comment on those. But the last question I want to put to the panel from me is this. Residential rehabilitation is something that gets talked about a lot, and is actually sometimes hotly contested in terms of what proportionate use looks like. But I see all the time people tell me it was the difference between entering meaningful recovery and not. And for many people in difficult circumstances, certainly with housing problems and a need to break a cycle, it can be absolutely instrumental. But we've seen a massive depletion in residential rehab. It's not something we can pick up straight away because the infrastructure has been depleted for so long now. What's the panel's view on what would you say to the government about investing in residential rehab? How important do you think it is for many people's journey? And what would you encourage the government to do? Carol, I think I know, I'll go to you first. Clearly.
Thank you, because we did pick it up in the review, and we echoed exactly what you have said, and what we thought was that the government should consider either, just like with some other conditions, you have a national service. You really make it such that there is either a national, or indeed it could be a regional service, and that you make sure that it is of the appropriate standard, because I think we would all have to agree that the inpatient detox and inpatient rehab, we are sadly lacking now in that service, but it was of variable quality. So I think what I was trying to recommend in my review was that we absolutely need to increase it, but we must increase it in a way that makes it equitable across the country, and really with to the right standards. Now, how much of that do you need, Adrian? I don't want to put a figure on it, but it is certainly much more than we have available. I mean, when you talk to people, to some local authorities, they said, well, they didn't think they were getting value for money, etc., when they've only got a certain amount of money to put into treatment and recovery. But we're way down, and of the 80 million the Treasury gave this year, I can't quite remember the percentage that's gone into inpatient detox and rehab. But you said something very important. You can't just say, we'll click a switch and we can start it again. You know, we don't have the buildings, we don't have the places, we don't have the staff, but it's a really important issue.
Thank you.
Sorry, if I could, yeah. So I think sometimes residential rehabilitation gets a bad name because of an allocation problem, in that sometimes it's the people who are best off get the residential care and need it the least, and the people who have very difficult lives and really need it are less likely to get it. So that's something important for a government to fix, and also to think about it in terms of a system. So we don't approach heart attacks by saying, well, you know, put them in the hospital and the second they can walk again, we'll discharge them to the community and wish them the best. There's cardiac rehab, there's follow-up. You enter into a care pathway and you're monitored. And the addiction field, we haven't always done a good job of that. We sort of, 21 days or even shorter, a quick detox and dump you back where you were. And most people will relapse in that situation. And particularly if they were on an opioid, they're at much higher risk of overdose when that happens. So it's building out the care system, which includes, by the way, recovery support groups and recovery activities as well, but also traditional kind of clinical follow-ups like you would give for anyone else who had been in a hospital.
Do you know, if I could just come in there, Adrian? I mean, I think Anne-Marie's put a really interesting statistic in the chat there. 0.5% of people in treatment in this country getting residential rehab, compared to 11% in parts of Europe. I mean, I'm surprised it's that high, to be honest, because the experience of somebody who's asking for residential rehab is the barriers that get put in their place are just unbelievable and immoral. The hoops that they have to jump through when they're in desperate help to try and get into rehab. And very often they're actually given the message. It still happens. It's easy if you want to get onto medication and substitute medication. But if you want to get off drugs and go into a rehab, it's incredibly difficult to access that. And that is just so wrong. We don't even really know who residential rehab will work for and who it won't work for. What we do know is that when people get their choice of treatment respected, it usually has a better outcome. And for me, if someone is asking for a particular type of treatment and they want to make that commitment and they've talked it through and they've been properly assessed and they're saying, yes, I want to come off drugs, I want to go into residential rehab, that's enough, and that should be their right to get that treatment.
Thank you, John. Well, we're going to move now to some questions from people watching this remotely. And the first one is from Hannah Sheed at Treby House. And I'll just read it to the panel. It says, it's an accepted view by many in our sector that addiction treatment has traditionally been designed around the needs of male service users. That we know that many of the women entering treatment are trauma survivors. They have experienced domestic abuse and sexual violence and would benefit from a specialist response delivered from a woman's service perspective. What more does the panel think we can do to better support women in addiction? And I think a follow-up question, how might this need be different when we consider children and their welfare? So, Carol, may I start with you?
Yes, it's a very a good question. I think it comes back partly to something John said earlier. To start with, in most local authorities, I think they wouldn't know what their need is. So I think you've really got to start at the basics of what in your community is the need, a really good needs assessment. And unless that's done, you can't commission well, as John was saying. You need then commission to those specialist groups, whether they're women, whether it's a chemsex group, whether it's whatever, whether it's young people, so that then you can bring in these smaller organizations and charities that specialize in supporting women. I saw a fantastic such organization in Manchester that really was supporting women who were in prostitution and on heroin. And and many, of course, were being abused at home. So I think it's knowing within your area, what have you got there? What is the specialist need? And then doing your commissioning properly to support that. And that's why we need more funds and more trained people. It is not done at the moment. There is just not the bandwidth to do it. But that's really partly what my report was trying to push for, that you really, really improve commissioning. And then you start to get down. And the question here mentions children. And I think we know that young people have suffered more than adults in the last 8 years in almost every respect of drug dependency. So it goes back to really getting to the root of what have you got, who have you got that could look after this specialist group. And at the moment, we just need more resources to do that.
Thank you. I'm going to open that to either one, Keith or John. Do you want to say anything?
It's hard to add such an articulate answer.
Of course. Okay, we're going to move on to.
I will just add to that. Sorry, Adrian. I do totally agree. I think that many of the services that we deliver are just not trauma informed at all, and we don't think through what it must be like for a vulnerable woman who has to come and sit in a waiting room where she's surrounded by males who, you know, she perhaps knows from the streets. And we put vulnerable women into mixed hostels with perpetrators and people like that. So I think it's looking at all of our services and offers through that lens, being trauma informed, and where necessary, putting on those specialist services for the vulnerable women that need them.
Thank you. Well, we are going to talk a little bit about justice now in the courts, and I suppose the first question here, we've seen, you know, recent developments in criminal justice and reforms around the probation service. We see the dynamic framework looking to try and commission more work in the community, service provision in the community. And we see also the simplification of out-of-court disposals, which more and more regularly across constabularies in the UK involve referrals to treatment. What potential opportunities do we see here about the criminal justice system expanding into better use of service provision in communities? And do you see the role of the probation service to engage more keenly in third sector groups that have real connection with people who are trying to battle drug addiction? I think, again, so John, I'm going to start with you on this one.
Yeah, I think one of the saddest things that I see in our systems when working with vulnerable people and people with complex needs is how they're dealt with in the criminal justice system. You know, despite all the knowledge that we've got about the effectiveness of these approaches, we still just see people with these horrendous lives where they've been traumatized from small children into adulthood, and they've got complex mental health, substance misuse behaviors, and it gets wrapped up, it manifests in offending behavior. And just so often society's response to that is just to lock people away. And I'm so encouraged by the work of family courts and, you know, the adult courts that look at a person in a fair and holistic way and bring in that team of experts. And it's more like a multidisciplinary team looking at how can we help this person and get outcomes.
John, can I just interrupt there? I mean, there are a couple of questions here around family, drugs and alcohol courts. So is that what you're referring to as well? Or
yes, yeah. Of course, you know, family, drug and alcohol courts and, you know, and adult courts where substance misuse is very much related to the offending. So I just think we need to see much more of this work rolled out, you know, obviously piloted and then rolled out across the country. And, you know, we give people a chance, you know, where they have complex lives and where there's offending. We try and help them. We don't just come at it with a punitive response that we know just leads to a repeat cycle of addiction and reoffending.
Very good, thank you. So is there anyone else who wants to comment on that question before we move on?
I'd quite like to come in, Adrian, because theoretically that is wonderful, but I think what we've seen over the last few years is fewer and fewer people referred to treatment and recovery in collaboration with the probation service, because the courts have not felt that it was either an adequate or a good treatment and recovery service, or they didn't have the right assessment in the courts beforehand. And we, you know, I addressed that as much as I could in my review, but again, to really address this, we need more resources to have the people on the ground, so that if someone is diverted into treatment and recovery, then there's a good service for them there. That it's not a service which they go into, but it's so bad that they just leave it, you know, and you're back to square one. So so many things need to happen in collaboration. And I think you will have read Justin Russell's review of the probation service in relation to drugs, and it makes very, very unhappy reading.
I suppose on the back of that question, and that if we can stay with you, Carol, there's a question here about employment, and it reads, how can we support people into employment when they have previous convictions which occurred whilst they were in addiction which prevent them from getting a job?
No, and this is a problem I certainly saw in my 2016 review. And when you did talk to employers, even those that were doing the right thing were very reluctant to put their heads above the parapets and say that they were willing to give people a chance. I think that the IPS model, which has been very much in localities, so it's individual placement support, case managers getting to know the local employers, really working with local employers in order to give people a chance, and through the process of support and case management, finding out what would be suitable, and support that goes beyond the just getting of the job, but into the job, because there will be bumps along the way. And I think it's a lot of hard work to work with employers at a local grounded level to see what you can achieve, and how you can encourage them, as I say, to give people a second chance. And we've shown very much in that trial that this can be done. But there will still be industries that do not walk this walk with you, and some industries that can't. But we could do much better than we do now, Adrian.
Thank you. I just want to say that there's also some commentary here that police could be trained, or at least, a question about whether or not there should be more police training to understand drug offences and criminality. And that's certainly something that's worth considering. I'm not putting that directly to the panel now. I want to move on to a different issue here. And one is around poverty. And this question reads as follows. Addiction is often a symptom of poverty. To what extent are the current challenges with addiction associated with a lack of a clear poverty strategy in the UK? Now, I can't see you all here, so I'm hoping that someone will chip in. So I'll open that to the floor.
I would say closely.
Closely.
I mean, I think we do need a proper poverty strategy, because I think it would map very closely to what we've seen in addiction. And I've talked several times to Donna Ward in DWP, who's closely involved with this issue, that the mapping is so close, that to work together on this issue. But I didn't think I could take poverty on as well in the review, but it's very close. It was part of, certainly very much in my mind, that these two things are moving together.
Thank you. John, I don't know if you have anything you want to add to that. Please don't feel obliged.
Well, working in an area like Bradford, it just brings it home to you so much how poverty and addiction to the most harmful form of drugs are just completely entwined. And it's a real social justice issue, because people who grow up in those communities are just disadvantaged from the start and more likely to end up using those most harmful drugs. So I certainly feel the linkage between poverty and addiction funding should clearly be made. The case is there that those are the priority areas for if they're given the worst start, they should be given the best opportunities later on, and they should be given the best quality services that we can possibly offer. Unfortunately, we do have this situation, as I think was mentioned earlier, where, of course, the people who have the most money tend to get the best treatment, and that should be really turned on its head.
Thank you. I want to just talk a little bit about psychosocial interventions. A question that we've received reads as follows. It says, given the important role of psychosocial intervention, such as talking therapy, and the role that they play in helping people achieve lasting recovery, does there need to be greater regulation of counsellors and psychotherapists? Perhaps I can start with Keith and then go to Carol.
I don't know if I would say greater regulation, because that might reduce willingness to participate in the endeavor. I would frame it differently as do we need more support and training? And I would say absolutely. So that would be, the capacity of not just, the traditional mental health fields like psychologists and social workers, so on, to take better care of addicted patients, but also teachers, people who do case management, people who work in run shelters where they're going to encounter people who are in addiction. And it's not you need to turn them all into, master psychoanalysts or anything, but just the ability to recognize the problem, express empathy, give people sensible advice, and direct them to resources. An investment of that sort, so that there's really no wrong door for people to get into recovery, would be a good one to make for public health.
Adrian, I can't really improve on that. I think that's Keith's put it very succinctly.
Thank you. Okay. I think there's an issue of what role family and can play in this. I don't know if any of you feel that that more could be done by the state to help families when they're supporting a loved one into recovery. Often people who support and love someone who's going through that journey can be crucial in making a difference. And sadly, sometimes people who are in difficult domestic situations need a little extra help. Do you think there's more the state could do to support families in this endeavour? I'm going to go to you, John.
Yeah, I mean, I think that what we do know is, of course, addiction is something that just doesn't just affect the individual; it devastates the family as well. And I know when I used to work in residential treatment, the standard approach was to work with the whole family. You didn't just have the individual patient. The care plan always involved the family. And the way I see services configured now in communities is we tend to have separate services for families, if there's a service at all, and we tend to call them carers as well for some strange reason, and give them some help over there, and then just work with the individuals who have the problem with drugs or alcohol themselves and not bring them together. And I think we've got the paradigm wrong, quite frankly. And with more investment and better quality services, we should be really looking at working much, much more in all of our services with the whole family unit. Having a family member who's involved in a person's care is going to give generally much better outcomes, and including them. There's often so much of the problem is about secrets and lies and lack of understanding and lack of communication. And we're almost setting ourselves up for more of that, the way we've currently got services configured in the community. So yeah, a completely different paradigm, I would say.
There's also a lot that can be done outside the state, just in the way that we treat each other. So, if you talk to families who, let's say their child has been in a terrible accident, or who gets cancer, they'll have stories about, well, the neighbors came over and somebody brought dinner over and were inquiring after me. How do we act when a family has an addiction in the child? Oftentimes it's shunning, blaming, implication you must have done something wrong, you were a bad father, you were a bad mother, and they already feel terrible. And this just makes it a more isolating and depressing experience. And to just extend the compassion we would towards any other parent whose kid had a really life-shattering health event, that's something we don't need the government's permission to do that. We can all start doing that today.
And Adrian, I just would like to sort of see myself more input from mental health social workers, for example. I mean, I think there are roles that could be developed that would support families. I mean, mental health social workers do work very closely with the families, usually with families with complex needs. And it's that sort of worker, again, with a little bit of training in addiction, you can think of roles which would be supportive of families. And I don't think we've given much, if any, consideration to that sort of approach.
Thank you. Look, just comments coming in sometimes rather than questions from people watching, and one from Anne-Marie Ward who says, latest research in Scotland says that you are 18 times more likely to die from a drug overdose if you live in our poorest communities. And it really sort of strikes a chord with the sort of fairly resolute indication from the panel that there's a close association with poverty. And it makes me think more and more about this commitment to level up in our country and how far short we're falling. One question here that perhaps less to do with treatment and recovery prevention, but it's still worth looking at. Alcohol advertising. We see alcoholism becoming an increasing problem in the UK. The question is, what role should regulation on alcohol and advertising and labelling play in creating a cultural shift in our relationship with alcohol? Does the panel have any views on that?
Yeah, I mean, I would say also cannabis, at least in my country, an explosion in advertising and promotion, tobacco. A lot of these ads are extremely skillfully designed. They are delivered in amazingly manipulative ways. I heard a story from a friend of mine who's a journalist of somebody who had a gambling problem and was in recovery and then was traveling, and there was a match that night and got a promotion offer. Hey, we can read from your GPS you're here. Do you know there's a match tonight? Would you like to place a bet right now? All that stuff really needs to be restricted. There's a fundamental conflict between when you're selling something that's addictive and the benefit of the population. The best customers are addicted customers. So from a purely capitalist viewpoint, your incentive is to spread as much addiction as possible, but the social harm of that is so overwhelming, we just can't let people do it. I think dramatic curtailment of advertising of all these products is entirely reasonable.
Thank you, Keith. If there's nothing else from anyone there, I think one final question that I want to pose to all three of you, and I'm going to ask all of you on the panel for an answer to this, and it's really to end this session. So this is a public policy area that can often appear marked by difference of opinion and sometimes some fractious and hot debate. But I see with increasing regularity an appetite for consensus about some of the core problems that we face as a country when we want to help people into recovery. And I can see a government that's making sometimes the right noises. In the spirit of that, what single ask would each of you make of government, a demand would you make of government that you believe that we can all get behind and support? And I'm going to go to you first, Carol.
I would like 5 years of secure funding.
Thank you. And you set out clearly in your report how that could follow. And I assume you would look for those figures to be met and honoured.
Yeah. I think that gives us the time, the space. We don't need any more reports or research to tell us there's lots we can do. And we're really now absolutely unable to do it. We don't just want 1 year of funding. We need to be, as John said earlier, in a position to know that we can start to build and make these changes that will then destigmatize our drug addiction. And let's try to make it really a health condition that we treat as we should treat it.
Thank you, Carol. Keith.
I would say something very similar. I mean, since 1946, this country has had a social contract where anyone is able to get health services. That's what the NHS is meant to mean. And to make that contract true for the care of addiction, I think would be a glorious achievement that would have benefits rating far beyond public health.
Thank you, Keith. John.
Ditto. Well, actually, I won't just leave it at that. But what can I say other than what my colleagues have just said? We've just got so much uncertainty right now, and we've got the hope, but we just can't change things. We can't plan. We're just wallowing a bit at the moment, aren't we? So we need that long-term commitment to the funding. and then we can really turn this thing around and just deliver the world-class treatment system that the people in this country deserve.
Thank you, John. So, yeah, thank you to all the panelists. It's clear that the scale and the gravity of this issue, well, that's very clear, but the future of drugs policy in the UK is far from clear, I'm afraid, and the inequality and the disadvantage suffered by many, I'm afraid, is a consequence of inaction, and it's unacceptable. And if the levelling up agenda means anything at all, then we would expect to see a spending review take on all those issues so articulately laid out today, and see addiction properly taken on as the Conservative Party promised in 2019. Can I thank you all for taking the time to, as a panel, to speak to us? And can I thank all of you who've sent questions in and comments in? They've been enormously useful. And if I can work out a way, I'll save those because they're worth further consideration. So thanks to all of you. And we very much look forward to speaking again.
Thank you, Adrian.
Thank